Hello and welcome to our live practical demonstration tonight where we'll be looking at shoulder manual therapy techniques. Now we've got 100% of 20 minutes of 100% practical here for you. We've got an idea of what we're doing. We've got a rough plan. We're going to run through a series of soft tissue and joint mobilization techniques. And despite talking through the presentation, I'm also going to try to stay 100% practical and just really try and show you as much stuff as possible during the session. So I've got my model here on the couch ready to go, and we're going to start off with some anterior techniques over the chest. My name's Daniel Lawrence from the Physio channel, and I've got here on the desk, on the couch, on the plinth, Richard Drazy, who has kindly volunteered to help tonight, although it didn't take too much persuading. Now, before I forget, last time we went live, we had a discount code from Rock Tape, which was only a short-term 24-hour discount code, and we've also got one tonight which gives you 50% off the mobility range, and that now includes the trigger point products as well. So the Rock Tape mobility equipment and the trigger point products, 50% off, a short-term code, and I'll share that code with you in just a moment, so make sure you have the ability to write it down somewhere and make a note of it so that you don't forget. So I'm going to start off with some supine techniques here, and I like to start here just by working generally over the anterior chest and over the pecs. And in a moment I'm going to focus a bit more and get down and a bit more specific onto the pec minor as well. But just working over the chest here can be a very useful way for helping to lengthen or to reduce tone in these anterior structures, and this can be very helpful for patients who have chest tension, and perhaps that has something to do with their pain over that area. It's also helpful to come across the clavicle a bit more there and to come into the upper ribs and to drop down and to target the subclavius as well. Now, the subclavius muscle is a small muscle going from the first rib to the outer part of the clavicle, and it's part of the deep front arm line as well, which includes the bicep and the pec minor. So getting in up here can also be another area that you don't want to miss if you're working over the anterior chest. Now I'm using my hand, using my fingers, all very useful, and I also like to use, no surprises guys, like to use tools as well, and these can be helpful and also a good experience for the patient as well. They often report that it's a therapeutic experience to use the tools as they have a nice smooth edge and they don't catch on the skin. And if you use one of the curved contours of the tool, then you can come down over the arm lines and then move into the chest as well. Having the passive control of the arm helps because you can move into more elongated positions and then combine the assisted stretching with the movement as well. Now, talking about stretching, that moves me on to the next technique, which is a PNF, or muscle energy technique. And from here what we can do is have a look first of all at the range of motion between internal rotation and external rotation. Now, if there's a restriction into external rotation, for example, and the patient is not suffering from any shoulder instability, which they probably wouldn't be if there was a restriction, then we can bring the arm back to a resistance point, which is around here for Richard, and then ask him to resist against any further external rotation. He resists there, and then after a few seconds ask him to relax. When he relaxes, we should be able to take that muscle a little further as the stretch reflex has been desensitized by that contraction, and then we can move into it a little further. The other thing that can be helpful with that is we add in the contraction. If you can do that again for me, Richard. So he's contracting there at end of range, and then relax, and then when he relaxes we actually ask him to go the other way. So he then moves actively into the external rotation to improve the range. And doing this 3 or 4 times, you can often get some significant improvements in range, which may not be immediately relevant in this position, but if they've got a functional movement, such as reaching up behind the head, you should find that something like that significantly improves after doing some treatment in this position. If they experience a bit of discomfort doing this, it might not be the appropriate technique, but before you decide it isn't, put a little bit of pressure. I'm in the wrong position here, guys, so I'm going to move around here. Put a little bit of pressure over the anterior shoulder, and that can help to stabilize and also make it more comfortable for the patient. So from here, you can do those same external rotation techniques with more patient comfort. Now, from here, I want to try and get into the pec minor. Hopefully you can see it on the camera. I've got our camera lady, Rose, is going to let us know if you can or can't. So I'm going to hold the arm out of the way and hope that you can see it on the camera. Using my fingers there, I can come in the armpit, in the axilla, the anterior axilla, and I can just tuck underneath the pec major and come in onto the ribs and find and then lock down over the pec minor. The pec minor, of course, comes from the coracoid process in the front of the scapula and then comes down to the 3rd, 4th, 5th ribs. Roughly on most people, of course, but that's where we're aiming. So we can come in there and lock into that position, okay? And that's our our trigger point technique for the pec minor. But we can do so much better than that. Now what we can do is move Richard across to the side, to the edge of the couch, please. Rich, your shoulders off the edge there. Okay. All right, he's moving very slowly. I think he's getting a bit relaxed. It's not a spa, Richard. Come on, wake up. So we can come in there onto the pec minor, okay? And then move the arm back, and I'm going to ask Richard then to pull his shoulder blades back, pull his shoulder blades together, which will move the origin away from the insertion, stretching the muscle, and then relax, okay? Furthermore, as I apply pressure, I can then move away from the coracoid process, as Richard does the opposite movement there. So we've got like a pin and stretch technique occurring. Now, if you're not comfortable getting in there with your fingers, or if your nails need a bit of a trim, then you may find it helpful, as we were practicing this on a course just the other day, using the tools here. I know you won't be able to necessarily feel some of the detail you can with your fingers, but look, the edge of the tool is smooth and blunt and is not going to cause any discomfort. And patients report that this is a very acceptable method of doing it. Also, something to think about, you're not putting your fingers into their armpits, which for most patients is fine, but of course for some, either you might not want to, or they might not want you to, or a combination of both. So with the tool there, just makes the experience a little bit less personal, a little bit more clinical. Whether that's good or bad, I'll leave that for you to decide. But you can get in there and do much the same techniques. And I'm going to ask Richard now if he finds this, if this is okay, if this is comfortable for him.
Yeah, it's
is this,
good.
yep.
Good then.
Okay, yep. He's given me a positive nod, so that's a good thing. All right, there we go. Okay, so in the supine position, I think I also had this one on my list to show you. Showing you some mobilizations. Oh, Richard's holding me nice there. That's a very nice hold there, Richard. Holding the shoulder there, we can now have a look at doing some mobilizations. So I'm going to ask Rich just to come back on the couch, just a small amount. Rich wants to have his scapula on the couch there, so I can then have a look and focus on the glenohumeral joint. I'm going to pull the glenohumeral joint to add a little bit of traction, just a little bit. I'm not going to try and dislodge his arm. And then from that position, I'm going to get my arm up into his armpit again, and then mobilize the shoulder anterior, posterior, okay? What we can then do is bring the arm out into more abduction, a little bit of traction or distraction, and then moving up and down from that position. Is that caught on the screen, all right? Yep, you can see that, guys? Okay, brilliant. Right, send us a thumbs up, please, if you're watching. We're not sure if we can get comments on Facebook. There was a glitch in the system which meant we couldn't see the comments when we were going live, but I think we can see comments on Instagram, and Rose is nodding. So if any comments come through and they're not difficult questions, then Rose is going to call them out for us. Another simple mobilization, guys, is to stabilize over the top of the shoulder there, hold the glenohumeral joint, the top of the humerus, sorry, and then just to mobilize from anterior to posterior, or from posterior to anterior, whichever way you're trying to promote, typically from anterior to posterior, to mobilize the shoulder. And this type of movement can just be nice and desensitizing for a sore joint, and can then usually be used to push forward and to migrate into other things. Okay. Jess, feel free to be on security if someone's trying to break in. All right, what's next on the list?
We have abducted exterior, interior.
Yep, okay, I have to remember that. This is a good technique to do, guys. We've put this one on the physio channel recently, but I wanted to show you this one as well. If you're looking for a soft tissue technique to promote external rotation, then holding the arm out into a suitable degree of abduction, and then the hand scoops around underneath the shoulder, and we're looking then to promote external rotation with some passive movement, but then using the hand to externally rotate the soft tissue around there as well. And this is a really good technique for you soft tissue manual therapists out there. It can be very useful for improving external range. So get this to work alongside your other techniques, and it really will work well. Okay, brilliant, there we go. All right, now a quick check to make sure Richard's still awake. He is still awake. Right, is that all the supine ones? I think we've covered those.
Arm elevated, exterior rotation,
Onto your...
blade over arm and chest.
Away or towards?
Onto, yeah, thank you, Jess. Onto your side now. I think we covered all of those. Right. Next, we've got Richard onto his side here. I'm going to do some work down the lateral side of the body here so we can start to move in onto the... Actually, I did miss one. Quickly onto your back again. Sorry, guys, I missed this one. I wanted to show you as well. From here, bringing the arm up into forward flexion, into elevation, we can do a couple of techniques. First one, we can lock in onto the scapula so that we can do a pin and stretch over the teres major and minor. And for this one, we lock onto the scapula. So we're trying to keep the scapula in position as we bring the arm up into elevation. And then, more for the lats, we come off the scapula, lock in below the scapula there, get a good old grab a load of lat in your hand if you can, and then bring both the glenohumeral joint and the scapulothoracic joint up into that elevated position where you push away and push down and get a good stretch through the lats. Now that brings us onto the side lying position that Richard was in there. And from here, we can continue that. And this is a good position because here it opens up the posterior area there so that we can move our technique not just down onto the lateral side of the body as well, but also migrate the treatment down as we come back over the lats there and move down towards the thoracolumbar fascia. Of course, all part of that superficial back line of, the back functional line of tissue as we come through. So I come in here, lock over the scapula there, over that border of the scapula, and just work there on the teres major and minor. I can do a little bit of shearing, so instead of gliding over the skin, I can come down, lock onto the skin there, and then move that arm further up into abduction and just really push and get some shearing force on the tissues underneath the skin rather than gliding over the top. And that tends to work best if the tool or your hand can stick onto the skin rather than glide across. So best done before you put too much emollient or wax on. And then we can move that down over the lats as we've been doing just there. Okay, from that side position. Now, another one which was very popular on the physio channel the other day, and that was the scapular mobilization. And so I seem to have wires going over here, Richard. Let's see if I can tuck that under your head. Okay. This one was a popular video on the physio channel recently, and I get great patient reports, not just myself, but my colleagues as well have let me know that they use this one a lot. So on their side, with their arm over your arm, and then your other hand is free to stabilize over the top of the shoulder, this hand comes through and gets in underneath the scapula. Now, if they've got a really stiff scapula and it's really not mobile and you can't get that scapular lift and get underneath, try just gently mobilizing them and then pushing them back a little bit into scapular retraction, and that may help you to get under the scapula a little bit further. Failing that, try bringing the shoulder into a bit more internal rotation. That may lift the scapula. But you know what? If you can't do that, you'll just try to have to hook your fingers on the border of the scapula, or, without too much emollient, place your hand over the scapula and just try and mobilize it generally and globally around there. It's more difficult. With some patients it will be, but it's still worth a go, because even if you get an extra 5-10% of movement, that could be significant for their function. So Richard's quite easy, actually. Tuck my fingers underneath there, and I'm going to do a few things. The first thing I'm going to do is to pull the medial border of the scapula away from the rib cage. So I've got some protraction movement coming on here. I'm not wrapping it around the rib cage yet. I'm literally just pulling it away from the scapula, and this is my first starting technique that I'm going to do. The next one, I'm going to start to abduct the arm, but make sure that the scapula comes with me. So holding the scapula and moving the arm into abduction, and then just getting that lovely scapular mobilization there, which is really going to be supportive of abduction movements and should lead to some carryover and improved function afterwards. Now the one that, I'll just do a couple more of those, the one that feels really nice is this more circumferential technique here, where we go right round, and it looks therapeutic, it feels therapeutic, and as you're doing it, it feels therapeutic. But what about the patient? What do you think, Rich? Any good?
Yeah, it feels good.
Okay. All right, guys, if you're watching, please leave a comment to let us know how much you think we should charge Richard for today's treatment, especially as he gets the star in front of you guys. We should probably charge him a little bit extra. Okay, coming through. Rose, if there's any questions, you are allowed to. None yet. Okay. Nobody said, "What are you doing to that man?"
I've got some thumbs up there.
Oh, yeah, okay, brilliant. All right. If you've just tuned in, you are watching a man massage another man. Please send through some questions. We will attempt to answer them. Okay. All right. Now, that's good. Hopefully Richard's enjoyed that. That seemed to work well. Haven't left too many nail marks that you'll have to explain to your wife when you get home later. Yeah. We have pod circles from the pods with nail marks on Richard, and he's still allowed to come and join us. I guess you've got video evidence, haven't you? Okay, I'll take this away now. Right. What's on our list for this sideline?
For a spin, use pods along the line.
Great. Okay, guys, let's crack open some pods now. I'll use these red ones. Hopefully they'll... Okay, so we're going to use some of these pods now. And if you're not familiar with these, then please bear with us. If you are familiar with them, then that's great. You'll probably would have done something like this already. So I'm going to go ahead and get these myofascial cups, these rock pods, these suction pods onto Richard there. And if you're wondering why, I shall explain just exactly why we're going to use them. So I like to think of these as handles. Have a look at this. It's holding the skin. It's not providing any downward pressure. It's providing a decompression, but it's locked onto the skin. So it's rather like, or not dissimilar from, a pin and stretch technique, if you will. But rather than pinning, we're lifting, and then we can mobilize. And if you can see on the camera there, when I move that single pod, the tissue's being moved all the way around his back. You can see the movement even all the way down at the lumbar spine here. So it's having a profound and diffuse effect as it really does grip onto the tissues. And of course that shows us what's happening superficially, but doesn't show us what's happening deeper down below. And it's not until you experience this, until you're the patient, that you can really feel that the soft tissue movement and mobilization is really quite deep as well as diffuse, and a very therapeutic experience. So we can put these on here and really get those moving. And we can then combine that, a combination treatment or some kind of treatment stacking, if you will, with these mobilizations as well. We can hold onto the pods and get a combination there of scapular movement